Hi, my name is Chandler Church, and I'll be presenting Presentations of Female Genital Tuberculosis, a case series from the University of Washington. So for some background, although female genital tuberculosis is rare in the US, worldwide female genital tuberculosis is a major cause of infertility. In some countries, such as India, where this has been studied, it is thought to be responsible for 10 to 20% of disease in women presenting for infertility treatment. As increasing numbers of women from tuberculosis endemic countries present for infertility care in the US, we'll see more cases here. So we reviewed our institution's database of patients, looking for female patients carrying diagnosis codes corresponding to genitourinary tuberculosis between 1990 and 2020. And then we chart reviewed those patients to confirm the diagnosis and abstract the information. Ultimately, we identified 11 patients who met criteria for having female genital tuberculosis. In general, the patients, which you see laid out here on this table, fell into three distinct categories of presenting illness. The top of the table, the first 5 patients that you see, all presented for infertility workups, usually through specialty OB/GYN infertility care centers. They presented with amenorrhea, infertility, miscarriages, or spontaneous pregnancy losses. And generally, they had a long lag time between the onset of these symptoms and the diagnosis of tuberculosis. Ultimately, most of these women did get diagnosed by endometrial biopsy, which now that it is no longer part of the standard workup for infertility care, is not done routinely early and is only done when suspicion for tuberculosis is considered. As you can see, many of these women had 2 or 3 years of time in the healthcare system before they were diagnosed. Some had PPDs or IGRAs performed, and most of those were positive. The next category of patients were women who presented with postmenopausal bleeding or adnexal mass. Generally, these were older women, and they usually presented to gyn-onc in the setting of an oncology workup. In general, these women had symptoms for a shorter duration of time as tissue was obtained as part of their early workup given the suspicion for malignancy. Generally, tuberculosis was not suspected prior to obtaining pathology in these patients. The last category of women presented more acutely with a shorter lag time in terms of symptoms. They presented with pelvic inflammatory disease-like symptoms or tubo-ovarian abscess or other pelvic abscesses. These women generally were ultimately diagnosed with miliary TB and had positive cultures from multiple sites. And so they were generally more acutely ill. So in conclusion, tuberculosis of the female genital tract is a rare disease in the US, but becoming more common. We noted 3 distinct presentations in our population, including infertility, women usually presenting for fertility assistance, often having undergone in vitro fertilization or other treatments prior to their diagnosis. Postmenopausal bleeding or adnexal mass, which usually presented first to gyn-onc and was treated as potential cancer. And PID or abscess, which often represented disseminated or miliary disease. Diagnosis remains challenging, requires high clinical suspicion. We recommend starting with a PPD or an IGRA, although a negative test in the setting of high clinical suspicion should not preclude further workup.